Hi everyone, welcome to our session today. I'm super happy to see all of you today here. Now, today we are going to talk about a very special part of ECG interpretation, and that's going to be atrioventricular block or AV block. Now, there's a lot of things which we can talk about when it comes to ECG, just like maybe atrial fibrillations, and we can talk about SVTs, VT, VFib, but we're not going to go there because that's all part of our course already. But I just wanted to make sure that we do specifically on this one, which is atrioventricular block, okay, AV block. So even if you don't know anything about it, you're going to be completely happy that you attended this session, because by the end of it, you will be able to interpret it, right? Now, before we go into details of this, it's important to know what exactly is involved when we talk about conduction system. Now, please remember, the heart's conduction system is way different from the cardiopulmonary system. Okay, I mean, usually when we think about heart, we talk about the heart pumping the blood, the pulmonary artery getting blood from the right side and going into the lungs. And we think about the aorta getting the blood from, the left side of the heart and giving it to the entire system. So that is one major job. I mean, that's great, but we need to get this electrical impulses in the right amount, in the right way, in the right area for this cardiac cycle to happen. That's what we are going to talk about today. And that conduction pathway is what is going to be the major thing which transfer the impulses from SA node to AV node to the bundle of hairs to two bundle branches and Purkinje fibers. Now, those words might get to be a little too much confusion here, so we're going to talk about that. There is a picture, and I think all of you guys know about SA node, right? SA node is the natural pacemaker, and it is on the right atrium. I mean, that's where it is situated. So if you look here it's right atrium side, that's where the SA node is. Then it should come to AV node, and AV node is supposed to be called a gatekeeper, and that is right there before it goes to the ventricle, right? The electrical impulses goes to the ventricle. So from AV node, there is a bundle of hairs and then two branches and then the Purkinje fibers. Now, this is a picture, but I'm going to show you a 3D model, which is going to be a little bit more there. Okay. Now, in this one, probably you can see how the conduction system goes. Now, if you see that yellow lines there, the yellow lines, there is a node here, and then the yellow lines comes, and there is a node here, and then the yellow lines goes down, right? So this is our conduction system. That yellow lines represent our conduction system. Now, if you look at that, so this is how the heart is. And you have the aorta, okay, that's where the big blood vessels and everything going. So this one, the beginning, that is the SA node. Let me write that down here so you can understand. This is our SA node, okay? And from the SA node, when there is an impulse going, it is going to go into the AV node, and that's down there. And you can see a little thick bundle after the AV node. Okay, let me get another color for that. Maybe I can take blue. Okay, you could see this, right? See this thick bundle here? Okay, that in that blue box, the thick bundle, that is the bundle of his. All right, that's the bundle of his, and that represents the septum. So if everything goes good, if everything is going okay, then the SA node will fire, which means the impulse. It will come through, it will go a little bit into the left side too, because both atria has to contract, right? So it will go to the left side too through that pathway. Then it will come down to the AV node, and AV node is like a gatekeeper just before things goes into the ventricle. right? And then there is this bundle of his, and then it is going to go into our bundle branches, then Purkinje fibers, and boom, it's done. And the next one comes. Right? That's how it goes. So whenever this P wave, whenever you see a P wave, you know that the SA node is working properly. Because when the SA node gives that impulse and it which reaches AV node, between that time, the atriums are contracting. That is called depolarization. Okay, when they are contracting, we say it's depolarization. That is contraction. So when they are contracting, when they are depolarizing, that's a good thing. I mean, that's what we want. We want the atrium to contract so the blood can come down. Now, who is making that contraction happen? This is the SA node. The SA node is giving the impulse so it can contract and things can come down. Now, when an AV node, when the AV node receives that impulse, first it will start contracting the bundle of His because that's so close. Right? That's a thick bundle so close. So the AV node is going to contract. AV node is going to send the signal to the bundle of His, and the septum, that's where the septum is going to contract. Okay. So when this happens, you get a P wave. When the septal area, right in that bundle of His, when that is going to contract, you get a Q wave. That's like the beginning of ventricular contraction, because after that it's ventricle. Right? And then the end comes, like, the ventricles are going to contract, because from the bundle of His, this impulse is going to go to the right bundle and the left bundle, making the entire or the big mass of the ventricle to contract. And that is going to come up as a R wave because it's major mass of the ventricle. And then at the end, there is main squeezing, the end of the squeezing, and that is the S wave. So when these ventricles are contracting with the impulse coming from the bundle of His through the bundle branch and the Purkinje fibers all together, there will be QRS. That's why we always say QRS represent ventricular depolarization. So P wave represent atrial depolarization, and QRS represent ventricular depolarization, because QRS is required. If there is no QRS, the ventricles cannot squeeze. If the ventricles cannot squeeze, then there is no cardiac output, right? So we need P wave, we need QRS. Now, whenever there is a conduction delay, sometimes there won't be QRS. I mean, there won't be any coordination. And that's when we say there is block, there is second degree block, or we say there is heart block, right? Or complete heart block. So that's a big issue. All right. So now we are going to talk about first degree heart block, and then we will go from there. Okay. Now we need to remember what is the normal PR interval. I mean, that's something we need to know, the number. But at least if you don't remember that, at least you have to remember it should not be more than 5 blocks. The ECG has small blocks. Okay. So up to 3 to 5 blocks is what normal is. I mean, it should not be more than 0.2. 0.2 seconds in ECG is 5 small blocks. Very small blocks, not the bigger one, okay? The small blocks, the smallest blocks, that is when 5 of them together, we will say it is 0.2 seconds. Okay, it's 0.2 seconds. 0.2 seconds or 3 to 5 small blocks. That's what it is normal. Now, if it is more than 0.2 seconds, that means it is taking longer to reach there. I mean, SA node gave the impulse, AV node is getting it, but there is some delay. It's not passing through. How do we know? PR interval is going to be longer. How do we know if it is longer? We count the blocks. We know where the P is, we know where the R is, and we know how this much is, and we can figure it out. So you can see that here, PR interval. From the P, beginning of the P to beginning of the R, or like you can say that the septum is going at Q, you can say that. So that is going to be your PR interval. So you're going to look at that, okay, from the beginning of the P wave to beginning of ventricular contraction, which is kind of beginning of the Q wave, you can say that. Right? So whenever that PR interval is going to be prolonged, that means the impulse is taking more time to get there and there is a block. And that block is called first degree AV block. Okay, so I'm going to show you how it looks like in the ECG. Okay. This is how it's going to look like in the ECG. Now, one major thing to remember, all the first degree AV block, when you see it at the first time, it looks like a normal ECG. So please don't mistake a first degree AV block for a normal ECG. Sometimes you will get normal ECG to interpret in the exam. I mean, they can ask you normal ECG. So just make sure that we count the PR interval, because at one, when you just look at it one time, it might look like, it's kind of normal, it might look like that. I mean, usually we see P, Q, R, S, T. Oh yeah, everything is there. It looks normal. And the rate may also be normal sometimes, So just make sure we look at the PR interval. So here, if you look at that, this is the P, this is the QRS, T, P, QRS, T, P, QRS, T. So you have that, nice way of going it. And when you look at it, it looks normal. But when you look at the PR interval from the beginning of the P wave to, sometimes you will be able to see the Q, sometimes you won't be able to see the clear Q. So that's why we are going to take as the beginning of ventricular contraction. And if you look at that, that is more. Okay, that's like more than 5 small squares. And this is actually 0.34 seconds. So this is the major thing you're going to look at. Okay, so very important. P is different from R. Right? So PR interval is going to be the one you are going to look for. Somebody is asking if RR interval will be the same. It doesn't matter. We are in heart block, RR interval has nothing to do. We are going to concentrate only on PR interval because that is what is going to help us to identify. Okay, because it can be so many different rhythms where R is all way out and it will be very difficult to say. So the thing we are going to look here is PR interval. And PR interval is going to be prolonged. How do we know that? More than 0.2 seconds or 3 to 5 blocks. If it is there, it's first degree AV block. Now, some things to remember. Whenever there is a first degree AV block, there can be no problem with the patient. I mean, the patient may not even know that they have a first degree AV block. First degree AV block is usually asymptomatic, okay? But it can become a problem later, but usually it is asymptomatic. I mean, there are cases where it progresses into second degree, progress into third degree. We have to watch for it. But first degree itself, if the patient is not having any bradycardia or confusion or there is nothing which tells us that there is decrease in oxygenation, there is decrease in cardiac output, then we usually don't do anything about it. Okay, so first degree heart block, there is nothing you have to immediately intervene. It's kind of okay, unless the patient is having problem. Right? So the second thing I want you to remember about first degree AV block is it might look normal, but don't get confused. Always look at the PR interval just to be sure that it is not a normal ECG, it is a first degree AV block. Now remember, even though there is a little delay, it passes, the impulse is passing through the AV node. So there has to be a P, there will be QRS, there will be T. There won't be any problem there. There is, it will be always there. There will be a P, there will be a QRS T, there will be another P, there will be a QRS T. That rhythm will always be there. All right. And the second thing is, or the third thing is, what is the reason? I mean, first degree, just like I said, sometimes, very good athletes, how we say, the sports people, like people who are like great athletes and all, they have bradycardia and it's not a problem for them. Just like that, for these people can have a first degree AV block also. But, even if they have a first degree AV block, it will not affect them until and unless they complain that there is a problem, or if you see that they are having hypotension, if they say that they are having dizziness, if they say that they are having syncopal episode, or if they feel that they are feeling so tired all the time. If there is something like that, then you have to do something. Otherwise, no. And medications can make it go down too. I mean, first degree AV block is, mostly is a problem or like a side effect of many medication. And the major one is the beta blockers. Okay, the beta blockers and all these anti-hypertensive medications, when we give them, and digoxin, that digoxin is a big thing. So all these medication which can reduce the heart rate, which it goes down, those things can make this happen. So if you get a patient with first degree heart block and they are saying they are having dizziness, they are having fatigue, what are the things you are going to ask them? You are going to ask them about the medication. What medicines are you taking? Because sometimes just by stopping that medicine or maybe changing that into something else, which is not having this effect, it might help them. I mean, that will be all you need to do. I mean, we have to talk to the doctor. I mean, we won't be able to change the medications, but at least we should be good enough to pick it up. Okay, sometimes there can be a question. What is the best thing to ask the patient? Patient is having first degree heart block. I mean, the first thing I want to ask the patient is, are you having any symptoms? Because I said, if you don't have any symptoms, am I worried about it? No, not really. Right? So I will ask if there is any symptom. And if they say they have symptoms, then I will also ask, what are the medicines you are taking? Because maybe that's why. We can stop it or we can change it into something else, and that will help, right? So we can ask them that. So those are the things you will be asking. And it can also be a problem if the patient had an MI or the patient is going through a surgery. So it can be a complication of MI and surgery and things like that. Because remember, the impulse is getting delayed, and we really don't know what is the cause of that delay. I mean, the cause may be because of medication, the cause may be because there is some issue going on in that area, like surgical issue or myocardial infarction. The myocardium is not, like responding to the stimuli because it's necrosed, because there was an MI. So many things can happen. So we have to make sure we understand that too. Another thing we will do for this patient is the blood work. Because, I'm sure you understand how this potassium level has so much importance when it comes to a normal cardiac, work, right? I mean, the potassium pump, sodium potassium pump, anytime there is hyperkalemia, hypokalemia, there's a lot of issue goes with all that problem with the heart muscle. So hyperkalemia can be one of the reason why there is, a problem, especially the heart block, first degree heart block. So it can happen at many times with the patient. So it can go from very normal to really bad MI or electrolyte imbalance. How do we know? We have to check the patient. We have to assess the patient. We have to ask the patient. We need to look at the blood work. We need to look at the history. And that's how we figure out, is this something normal or is this something we need to work on? Okay, so all those questions are important to ask to the patient. Do not assume that things are okay because it's just first degree heart block. I mean, maybe it's okay if the patient is not having any symptoms or any history or taking any medication, but if there is anything with it, then we have to act on it. Okay, so that is first degree heart block, and these are some of the medications which can, make it worse. And when you get the recording, you will be able to stop the video and you will be able to write things down. So you will have all this available. Right now, I just want you to listen to me, okay? Because I don't want you to, get your valuable time writing and then forgetting it. So just listen to me too. That way you will understand. So these are some of the medications which can cause a first degree heart block. These are mostly the same medicine which can cause the second degree and third degree too sometimes. All right. So this is how we know, like we said, how we know that there is a first degree heart block. Now, one thing I want you to kind of connect it is, I have heard this from somebody else. It's about how a husband and wife is, and it's kind of easy to remember that way. So let's say P wave is the wife and QRS is the husband, right? So they're married, they're having a good day and they're going a good life, no problem. Then he was in the hospital. I mean, not in the hospital, sorry, office. I mean, I always think about hospital. Let's say the husband works in his office, right? So every time the husband is going to the office, I mean, the wife is sitting at home waiting for him to come back. And usually the normal time for the husband to come back is, let's say, around 5 p.m. Every day, every evening, the husband is supposed to come back at 5 p.m. from the office. And things were going good, no problem, there was no issue. And then what happened was the husband started coming a little late. He comes every day, he comes every night. He comes home from the office, but instead of coming at 5 p.m., now he started coming at 6 p.m. Every day coming 6 p.m., right? And so the wife is having some issue. You know how the women are. They are always looking for clues, what's going on, right? So the wife just, she took the shirt off the husband and she tried to see if there is any lipstick marks or something, something which is going, because you know what she is thinking already, right? And she asked the husband, and she couldn't find anything, but she asked the husband, what happened? Why are you always late now? It was not like that before. You used to come at 5 o'clock all the time. Why is it that always 6 p.m. now? And the poor husband says, lady, I have a new boss and there's a lot of projects. I'm not able to come out. Okay. I mean, that's why I'm late. And the wife is like, okay, fine, no problem. Right. So she is actually watching. She is actually watching to make sure this is the project which is, keeping him busy in the workplace, not anything else. So she has the watch there, but probably it is the project. We don't know. We will figure out later. But as of now, things are going smooth. Everybody are watching. Everybody knows there is a problem, but it seems like it's not a big enough problem. So we are just letting it go. All right. And then let's say she figured out it's not the project. Let's say it's the traffic. I mean, he actually gets out, but then the traffic is so bad, so he is coming home a little late. I mean, there is nothing we can do about it. So we are just going to watch. If the traffic is getting really worse, then maybe he has to take another route. And we'll think about that. Okay. So if the traffic and the project, those are our medications, those are our MI problem, all those things which can make a delay in coming back. But as long as everything is stable, there is no big problem about it, we are just going to let it go. That's why I said type 1, or not type 1, the first degree heart block, if the patient is not having much of a problem, we are just going to let it go. We are going to watch it, but we are going to just let it go. All right. So anytime you get an ECG, first thing you need to look for is, how does that look like? Is there a P wave? Is there a Q wave following it? If you look at that, every P wave have a QRS. This P wave has 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 a QRS. So basically, it's like a normal ECG. The only thing is the PR interval is little longer, and that should help us. Okay, that's how we know it's first degree AV block. Is that clear to everybody? First degree AV block. We will do more examples later, and then we will figure out if we can get it. But I think it's at least it's clear to you, right? So just that much. All right. So remember that it might look like normal. It might look like there is a P and QRS all the time. It might look like there is no problem, but look at the PR interval, right? That's the best thing we can do. All right, guys. So now we are going to go into okay, this is some of the tips which I thought will be helpful, which I already talked about. Sometimes the patient will have symptoms, Okay, that's something we need to ask them or assess them. And if they are saying they have dyspnea, like shortness of breath, or if they are having their chest pain, or if they are always complaining of fatigue or weakness or malaise, okay, or if they are having their syncopial episode, those are some of the clues which is going to tell you this is not something normal, there is something else going on. This is not the office project, there is something else going on. Okay, that's when we know this is not something we are just going to let it go. We need to work, we need to intervene, we need to do something, right? But most of the time it will be okay. Now, if medications are the cause, it's easy to fix, like traffic. If traffic is the problem, we can always take another route. You know, that's easy to fix. So just like that, if medications are the problem, what we can do is maybe the doctor can order some other category of drugs which does not affect, you know, that bradycardia issue. Okay, so just watch for the worsening of the condition. Okay, so that is first degree heart block. Now, that's the easiest one, actually. In all three heart blocks, first degree is the easiest one because we just have to look at the PR interval and we will figure out, you know, it's easy. But now the second degree, that is a little complicated one, but I want you to pay attention. We'll do that. This is the, you know, don't worry about what is written there, you will get it. The second degree, when we talk about second degree, there are two kinds of blocks which can come in second degree. There is type 1 and there is type 2, right? And type 1 is also called Wenke-Bach. And it is also called Mobitz. Now, you must be thinking, what kind of names are these? You know, Wenke-Bach and Mobitz. Why don't they just call it like second degree type 1? I mean, that's enough, right? But there is a reason, and I will show you who is the reason. These two people are the reason behind it. See, these two people were like a great cardiologists, and this guy, his name is Karl Friedrich Wenke-Bach. So you know where that comes from, right? He's the one in 1899, he's the one who actually saw it first, the second degree heart block. At that time, we didn't have two kinds. We just have like second degree heart block, that's it. Now, after some time in the 1920s, this guy came out. His name is Waldemar Mobitz. Now, you know, if you're a Harry Potter fan, it's similar to Voldemort, you know, kind of like that. But this Mobitz, this person, this cardiologist, he is the one who made it into two kinds. He figured out that the second degree, there are two kinds. There is type 1 and type 2. So we gave his name to it, Mobitz 1 and Mobitz 2. So now you know why there is Wenke-Bach and Mobitz. I mean, it's just the name of the people who actually figured it out. And that's a great invention, right? So here we go. So second degree, two kinds, type 1, also known as Wenke-Bach, or it's also known as Mobitz 1. And in that one, what happens is, you know, remember our PR interval? Okay, let's go back to our husband-wife scenario, okay? So in first degree heart block, the husband was coming home every day, the same time, but he was a little late. I mean, instead of 5 o'clock, he was coming every day at 6 o'clock. I mean, that was the problem. PR interval was prolonged. But in second degree type 1, what happens is the wife is there at home. Okay, now she's at home, she's waiting for her husband. And today he came at 5 p.m. and the wife was so happy. Oh my God, he's back to his normal routine. I think the projects are over. I think the traffic issue is over. I mean, I think everything is back to normal, right? And then tomorrow he comes at 5:30, right? And the next day he comes at 6:30. And the third day and the fourth day, he didn't come. Right? Now there's a problem. Right? So the first day, he came on time. The second day, he's a little late. And the third day, he's later. And then he didn't come. Then again, he comes on the right time, 5 p.m. So that's kind of a schedule which the wife is observing now. And she knows there is something else to it. It's not just any projects or traffic. There is something more going on. I mean, she is getting that. So what is going to happen to the PR interval here? The PR interval can be shorter in the beginning. Then the next beat comes, the PR interval is a little bit more longer. And the next beat comes, the PR interval is a little bit more longer. And the next beat, there is no QRS. There is no husband, only P. Does that make sense? Let me show you that how that looks like. This is how it's going to look like. So you have a P here. This is your P. Then you are a QRS. So you see there is a PR interval is not that bad. It's really good. I mean, real good, no problem. Then comes a little bit more. Now, if you look at that, let me show you. This is the first PR interval, and then you have the QRS. Okay, and then you have the T, which is really good. It's relaxing, and then comes the next P wave. This is your next P wave, and this is your QRS. So what happens is, look at this one. So this and this is definitely more compared to this one. And then you have the husband coming, no problem. Then there is relaxation, no problem. Then again, the wife is waiting there, and look at that. He's taking longer. Here he came at 5 o'clock. Here he came at 6 p.m. and now he is probably coming at 7 p.m. And the next day he's not there. He's not there. QRS is not there, right? So there is dropped QRS, and that's very important to remember in second degree type 1. Two things to remember. Number one, PR is going to be longer and longer. Okay, PR interval is going to be longer and longer. P will always be there. P will be always on time. P will be regular. P is just sitting there on time. It's the QRS who is taking longer to come. So PR interval is going to be like this, then little more, and then there is no QRS. So there will be dropped QRS. Dropped QRS. Okay, I think it's written here too. So PR interval getting longer and then no QRS. And then again in the next beat, it goes back to the same scenario. Like here, if you look, PR interval, then it's getting longer, then it will be even longer, and then it will drop. So that's how it's going to go. So every time in type 1 of second degree block, if you count the number of P and Q, right, there will always be like in 1 6-second beats, if you count that, or like in a beats, you will count that, there will always be at least one dropped QRS. P will always be there, but the QRS will drop. Then the cycle will repeat. That's what is going to happen. Now, what is the problem if the QRS is not there? What is the problem if the husband is not there? What's the problem if the QRS is not there? What is QRS representing? QRS is telling us that the ventricles are contracting. I mean, that's what we are looking for. Now, if the ventricles are not contracting, what is going on? Nobody is getting any blood. Not here, not here, not here, nowhere. Because only when the ventricles are contracting, that's when the cardiac output works, right? I mean, that's when things are going to go into the pulmonary artery for oxygenation, and this way to the lung, to the aorta and the entire body for helping our all organs. So if the QRS is not there, that's a big problem. That means there is a problem in cardiac output. People will have issues. Now, this also sometimes can happen asymptomatically. I think everybody knows that word by now because of COVID. We hear a lot about it, that people can be asymptomatic. People can be asymptomatic, still put on mask, right? So just like that. I mean, they're asymptomatic means you're not showing any symptoms. You don't feel, fatigue, or you don't feel anything different, but you still have it. It can happen like that. Okay. So to understand or to identify this problem, there are a couple of things I want you to remember. Number one, you're going to look at the ECG and see if there is a dropped QRS. which means, is there a QRS along with each P? Okay, if there is no QRS, if there is a dropped QRS, then you can safely say it's not first degree, because we know with first degree, all P should have a QRS. We know that, right? And we are sure about that. So if it is a dropped QRS, that means it's not first degree block anymore. This is probably a second degree block. Now, in second degree block, we know there are two kinds, and in both of them, there will be dropped QRS. Now we have to figure out if it's a first one or a second one. And the way to do that is PR interval. Look at the PR interval. If it is getting longer and longer and longer before dropping it, then it's type 1. Okay, because in type 2, it is different. I will show you how that goes. So in type 2, let me show you. So this is type 2. In type 2, what happens is this. Okay, now if you get this, first of all, we are looking to see if there is any QRS with each P. Now I looked at this P, there is a QRS, we are good. There is next P, there is a QRS, we are good. But then there is no QRS, right? I mean, how do we know if this is type 1 or type 2? We look at the PR interval. Now, what do we know about the PR interval for type 1 second degree? We know the wife is waiting and the husband is taking longer and longer and longer before he stops coming. But here, that's not there. Here, the scenario is, you know, the husband is coming every day at 5 p.m. He's there. Today, he's there at 5 p.m. Tomorrow, he's there at 5 p.m. And the next day, he's there at 5 p.m. And then he doesn't come. So there is no warning sign. I mean, he didn't even give us any warning sign. He just stopped coming that day. But again, he comes the next day, right? Because in type 1, we had enough warning sign. I mean, the wife was waiting there and she was like, today he comes at 5. Very good. Tomorrow he's 6. Oh, that's not a problem. So there's something wrong. Then the next day he's coming at 7. Oh, that's even worse. And then the next day he doesn't come. That's like really bad. So we had enough warning sign before there was a drop in QRS. That's second degree type 1. The PR interval gets longer and longer and longer. But here in second degree type 2, there is no sign. There is no PR interval getting longer. PR interval is correct, but he just didn't come the next day. That's it. Okay. So what means here is, if you look at the PR interval, you will see that PR interval. I mean, it's not really easy to see, but still there is a PR interval here. There's a PR interval here. There's a PR interval here. PR interval here. So if you look at the PR interval, it's all normal. It's good. He comes on right time. But what is the problem? PR interval, PQ, no problem. But then there is a P, there is no QRS. He didn't come, right? And that's why this is type 2 in second degree heart block. Okay, so that's the major difference. How do we identify? Always look at the ECG and see if there is a P and QRS for each beat. If there is a P and QRS for each beat, then that is good. Then look at the PR interval. If it is longer, there is a P and QRS, but the PR interval is longer, that is first degree. Now, if the PR interval is there is Q dropping, then it's second degree. Now, in second degree, if the PR interval is getting longer and longer and longer before it drops, then it's type 1. If there is no change in PR interval, but suddenly it drops, then it's going to be type 2. Okay? So I hope that is clear to everybody how you do that. We will do more exercise, which will help you to understand that. But let's go back to the theory of it. What can cause the type 2, or what can cause the second degree heart block? Okay, so we are going to look at that first. In second degree heart block, or the Winky back, okay, usually the things which causes the first degree heart block, that can cause the second degree heart block too, especially the medications. So one major reason is the medication. Then, like athletics, like we said, they can have it. MI, post-surgery people can have it. But remember, most people are asymptomatic. So what we are going to do in these cases, just like in type 1, first degree, just like in first degree heart block, we are going to assess the patient first. We are going to check if the patient is having a problem. We are going to ask the patient, do you feel anything different? Are you feeling weak? Are you feeling, fainting, or did you have a fall? Or is there any problem? That's our first question. Now the patient is saying, no, I don't have any problem, nothing, no problem, everything is cool. Then we are okay, good. We will just watch, right? Because its patient is asymptomatic. If the patient is asymptomatic, we are okay. We will watch. We are not saying that we are going to just ignore them. We will watch for any difference or progression, but it's not going to be a priority patient. Even if it is, second degree heart block, type 1, but the patient is not having any symptom, maybe not my priority patient. I'm not ignoring him. I'm still taking care of him. I will watch him. I will put him on cardiac monitor. I will check his medications. All that is there. But if I have to choose a priority patient, maybe he is not the one. Okay, because he's asymptomatic. Now, everything changes if the patient is telling you that he is having chest pain. Okay, everything changes if the patient is telling you that he is having shortness of breath. Then things are different. Things are very different. Then that becomes my priority patient because he is going to go into complete heart block before I know, right? So that's something we have to be very careful. Now, in type 1, in these patients, we might be able to help them if they are having, these symptoms, bradycardia symptoms. We will be able to possibly help them with some atropine. Okay, so let's think about our husband-wife scenario in type 1, second degree heart block. Remember how the wife was waiting and the husband was getting longer and longer and longer to come, right? That is what we are talking about here. So let's say when the wife realized that, he is taking longer and longer to come, the wife kind of smelled that there is something wrong. So what she did, she actually went and saw a counselor. They went for a family counseling. Let's say they went for a family counseling. Okay. Now the counselor was able to, check with both of them and do the counseling. And let's say he was able to make it all better. Okay. And that counselor is our atropine, right? Bradycardia, what is the major medicine we use in bradycardia? Atropine. So in these patients who have symptoms and they are type 1, not type 2, type 1 in second degree. Okay, this is second degree AV block type 1 or Winky-Back or Mobitz 1. In those people, counseling might work. Okay, it might be enough. Not all the time probably, but most of the time counseling will be enough, which means if you give atropine, that will probably take care of their problem and they will be fine. Okay, so if that works, that's the best. Now let's say they went to the counseling, they saw the counselor did everything he could and it didn't work. Okay, after a couple of days, things are back to this. Then what are we going to do? Maybe we need to kind of involve more people. Maybe we need to get a lawyer or somebody involved. Okay, or maybe some, religious priest or somebody who is like, someone who has such a big say in this patient's life. That's what this married couple's life. That's what we are going to do. Let's say it's a lawyer. Maybe we need to get the lawyer involved, right? And that lawyer is going to be our temporary pacemaker. Okay, the lawyer is our temporary pacemaker. So for these people, second degree heart block type 1 or Winky-Back or Mobitz 1, okay, we will try the counselor first, which is atropine. Okay, all these things are if they are symptomatic, if they are having problem, right? If they're asymptomatic, we are not going to do anything. We'll just watch. We will just monitor, make sure, right? So if they're having problem, first thing is the counselor, which is our atropine. And if it is not working, a little bit more steps, which is the lawyer, and that is our temporary pacemaker. You know, sometimes when you talk to the lawyer and all the things are involved in probably getting a divorce or something, it's going to probably stop them from, you know, rethinking everything. Or sometimes it might be like an agreement or something which they can probably reach. I mean, I don't know, I'm just thinking. So that is going to be the temporary pacemaker. All right, it works, it may not work, we will watch. Maybe they are going to end up in divorce, maybe they are going to end up being the perfect couple, we will watch. Okay, that's what we are going to watch for. So that is our second degree type 1. Right? Now in second degree type 2, there is no counseling, okay? Because this husband did not show any symptoms. There was no warning sign. I mean, he comes really on time every day at 5, and then suddenly he doesn't come. And then he repeats it again and again and again. I mean, nobody is going to just, let that happen like that, right? So even if there is this kind of, something we try to do, the counselor stuff, it's not going to work. Actually, it's going to make it worse. So there is not going to be any atropine. Atropine is going to make it worse in type 2. Okay. So in type 1, you can use atropine. Type 1, we can do counseling, but type 2, no. Atropine is not a good choice. And scientifically, it's not a good choice because it's going to make it, the conduction even harder. So we don't want that. So type 2 in second degree, no atropine. The best thing to do is pacemaker. I mean, that's the best thing. We don't want to try any counseling. You just go for, pacemaker. We just go for the lawyer because this is serious stuff, right? Between type 1 and type 2 is very serious, right? Type 1 and first degree, we are okay. If they are not symptomatic, we are fine. But type 2 is a problem. They can go into complete heart block real quick. So when you have a type 2 patient, when you have a second degree type 2, we are worried. And remember the ECG, remember the wife and the husband. The wife is sitting there all the time. The husband is coming back the correct time. 1, 2, 3 days he came on the right time, then he didn't come. So PR interval is the same, but then there is a drop. PR interval is the same, then there is a drop. Now, how many times? We don't know. Sometimes it's like 2 days he is coming in the right time, then he doesn't come. Maybe he's taking 3 days he is coming on the right time, then he didn't come. So it depends on how many days. Sometimes we say as a ratio, like for every P wave, how many QRS are there? Like sometimes it will be like there will be 1 P wave, 2 P wave, and then there is, QRS is not there. So 2:1 or 3:1, we sometimes refer to that into that ratio. Now, you don't have to know that much. Just know that the PR interval is going to be the same in second degree type 2, but it just drops the QRS in between. That's when it's type 2. Okay. Now, I want you to remember the reasons though for type 2, and that is these ones. Okay. Mainly, like everything which we talked about in our first degree and second degree type 1, those medications, MI, surgery, all those things can affect, but there are some new things which might cause the type 2 problem, which is more serious problem. And especially I want you to remember the autoimmune disorders. Okay. So whenever these people who have autoimmune problem like SLE, which is systemic lupus erythematosus, right? SLE or scleroderma or multiple sclerosis or all those kinds of autoimmune problems, there can be fibrosis. And heart is also muscle. I mean, myocardium is a muscle. So this muscle can get fibrosed. So when there is fibrosis, the electrical conduction is not going to be happening in the right way. There can be problem. And that is one of the reasons for type 2. Okay, type 2, second degree, type 2. So autoimmune disorder, inflammatory cardiac disorder. Inflammatory meaning like your endocarditis or myocarditis, that kind of itis problem, that is inflammatory cardiac problem. Lyme disease, please remember that. Lyme disease can cause second degree heart block type 2. Because of the scarring, it can happen in the myocardium, okay, Lyme disease. And mitral valve repair, when we are in a valve repair, when there is valve repair, that can be happen. Hyperkalemia, we saw that too, right? In first degree also it can happen. So it can happen here too. Hyperkalemia is always a problem. I mean, because it messes up the cardiac rhythm and the potential, action potential, everything is messed up when there is, high potassium level. So that's one. But these are some of the things which are very important. Now, speaking of this symptom-wise, remember type first degree heart block and second degree heart block type 1 can be completely asymptomatic. But when it comes to second degree type 2, most of the time patient will have some symptoms. And they may not recognize that as a heart problem. They might say, oh, I'm just having a little bit of shortness of breath because, I ran a little bit or I was working out or something like that. Or they might say, oh, I think I'm feeling a little tired today because of all the work or because of the weather. I mean, they may not really put it with heart problem, right? So we have to be very careful when assessing the patient, when asking the right questions. We have to make sure that we address that, and we should be able to connect the dots. Oh, this patient is saying he's having fatigue. This patient is saying he is having fainting or dizziness. Maybe let me check at the heart rate or the rhythm. And when I check the rhythm, I saw that there is PQRS, 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 no problem, and then there is no Q. And when I looked at the PR interval, it seemed like everything is perfect, but then there is no Q. That is what is causing the decreased cardiac output, which is causing the dizziness, the fatigue, the problem, because the ventricles are not contracting, right? You're connecting the dots, right? So when QRS is not there, that means there is no ventricular contraction. There is no ventricular contraction, meaning decreased cardiac output. Decreased cardiac output means you are going to be tired, you are going to be venting, you are going to be short of breath, all the problem. Okay, so that's why we are worried about. And these people, okay, we don't want to give them atropine. Remember, atropine is only for second degree type 1. For second degree type 2, we will not do any counseling. We will go direct to the lawyer. Okay, we will go to the pacemaker. I mean, that's what is that they need, because we don't want to take the chances of complete heart block. They can go into complete heart block real quick. We don't want to wait for that. There is no time for counseling here. Things are already out of our hand. There is no time for counseling. We are going to go direct to the lawyer and do what is required to do, right? So it's going to be pacemaker. Got it? Okay, that is second 2. So let's go back to the ECG again. Look at that PR interval. It is normal, good. Then there is no QRS. So this is what second degree type 2. Got it? Is that clear? We will do more ECGs later, and hopefully you will be able to answer me by seeing them itself. Now, you know the difference between first degree. Remember, first degree was everything looked so perfect. The husband and wife was there all the time together. The only thing was the husband was a little late, but he was always on time. I mean, he was late, but he was right there on that time. If he was coming every time at 6 p.m., I mean, maybe he was coming a little late now, but he was there, right? So PR interval was a little longer in first degree. In second degree type 1, PR interval was getting longer and longer and longer, and he didn't come. And second degree type 2, PR interval is the good one. There is no warning sign, but boom, he didn't come. Right? So that's what is going on. Okay, guys, so let's go to one question and let's see if we can figure this out. Okay, I hope you can see that. A healthcare provider is caring for a patient with a diagnosis of first degree heart block. Well, you're already given the diagnosis here. Okay, they are already saying this is a first degree heart block, right? And which rhythm is expected to be found in the monitor? Which means out of these four things here, which one is the first degree heart block? That's what the question is asking, right? So what I'm going to do is I'm going to give you a poll. You know, there's a down there is a poll button. I'm going to give you a poll, and then you will be able to, let me see if I can put that. Oh. Okay, I was hoping I could use this poll function, but for some reason it's not working here. So it's okay. You can just type in the answer in the chat window, and then we will go from there. Okay. So there are 4 pictures here, and if you can, great. You guys are already answering. I'm very happy about that. So 1, 2, 3, and 4. There are 4 options. Which one is the first degree heart block? First degree heart block. Make it a little bigger. Okay. All right, I will let you think about it. Think about it, look at it, and don't make any mistakes, because you know how first degree heart block is, right? You know how first degree heart block is. The only thing you are going to see is the PR interval is longer. There is no dropped Q. Now, if we know there is no dropped Q, there is always a Q along with a P. We can definitely take out 2 because there is a dropped QRS here. So we know that is not first degree, because in first degree there will not be any dropped Q. Remember, the husband was late, but he was coming every day. I mean, he was supposed to come at 5, but now every day he is coming at 6 p.m. But he is there. Every night he is there. He's late, but he is there. That is first degree. Right? Very good, very good. Now I'm seeing some good answers there. So the answer is this one, or number 1. All right. So if you look at that, you can see that here. Let's see if I can get that. Remember, there is a P, there is a QRS. There is a P, there is a QRS. There is a P, there is a QRS. P, QRS. P, QRS. P, QRS. So every P, there is a QRS. There is no problem there, right? So the only problem is, this part. The PR interval. And I'm not sure if you will be able, you cannot probably see the small ones in there, but the PR interval is a little longer. Okay, so it is there, P is there, QRS is there, there is no problem, but PR interval is longer. So our answer here is this one. Okay, now why not this one? Because there is no Q. And we know for first degree, the Q is always there. He comes home every night, right? So definitely it's not that. Now, these 2 are actually normal sinus rhythm. Okay, so this is normal. So 3 is normal, 4 is normal. And that's why type 1 might look like normal, normal sinus rhythm. but if you really count the blocks, you will be able to see that PR interval is longer. Okay, so that's how you will figure it out. Okay, now we are going to go into the third degree heart block. Okay, the third degree problem. Let me stop that. There we go. This is also called complete heart block. So sometimes it will be like, third degree. Sometimes they will say it's complete. Either way, this is the huge issue. These people, they are already kind of separated. Okay, they're not married anymore. They're separated. Now the next thing they can do is probably get a divorce and carry on with their life. I mean, that's the best thing we can do. So in these people, we need a permanent pacemaker, right? And because they are divorced or they are separated, these two people, meaning the P and the QRS, they are not going to be working together. I mean, there is no connection between them anymore. The wife has her own schedule, the husband has his own schedule, and they are living their life completely differently. There is no association. Instead, we will say there is dissociation. Okay, that's the word which you might say. Dissociation, which means there is no connection. They are independent of each other. They are already living their separate lives. Okay, that is this, this one. And in this one, you have to remember there is complete conduction. The conduction does not happen there. So the P wave may be coming. Okay, SA node is giving the impulse, P wave is coming, but it's not going to go through the AV node. It is not reaching the ventricle. So ventricle is going to contract itself. Ventricle can also contract. Whenever the SA node is failing, the ventricles are designed to contract. So SA node will have its rhythm, and this, QRS will have its own rhythm. That's what is going on. Let me show you the ECG, which you will be able to see how the complete heart block happens. And in this one, when you monitor, we can monitor the blood pressure, we can monitor the pulse rate, we have to take it as a priority patient, and it's very important we do that. Okay, so hypotension can occur, but let me show you. This is the ECG. Right? In this ECG, if you look at that, there is a P wave. There's a P wave here. There is a QRS. Okay, that looks nice. Then there is something here happening, but there is no QRS. Okay, we can see there is the QRS is here. The contraction of the ventricle is there, and then there is a T wave, which means the relaxation is there. Then again, there is a P wave, which is the atrium, which is also good, but then there is no QRS. And then there is no P, but then there is a QRS. So which means P is not in association with QRS. So let me show you that. So no Q, no QRS. And there is a QRS here, but no P. Okay, there is no P before QRS. Then there is a P here, there's a P wave here, but no QRS. Then there is again a P wave here, but no QRS. Okay, there is no P, there is no P here. Okay, which means P and QRS are not talking to each other. They're separate. Both of them have their own schedule. Nobody is talking to each other. Okay, so in that case, what we are going to do is, we have to make sure that we do something to kickstart. And that's why the pacemaker is so important in these people. If you get a complete heart block patient, definitely they will have symptoms. They will have maybe chest pain, they will have low blood pressure, they might have fatigue, they might have shortness of breath, they might be showing all these symptoms of reduced cardiac output. And the only way we can help them is by giving them a pacemaker. Otherwise, it's going to go into cardiac arrest, and then we won't be able to save them. So they need a pacemaker. Okay, so these are the people who are having 100% problem, and that is complete heart block. In the ECG, you will see that, let me take this out. In the ECG, you will see that P is having its own way of going, QRS having its own way of going. There is no connection. Every P doesn't have a QRS, every QRS does not have a P. There is no connection. Okay, so that's how we know. But if you look at that, if you just look at the QRS is kind of regular in its own way. I mean, it's not associated with P, but it's regular in its own way. If you look at that, between these two, 1, 2, 3, 4, 5, 6, 7 boxes. 1, 2, 3, 4, 5, 6, 7 boxes. So if you just look at the QRR, you will see that it's kind of regular, but it is not associated with the P wave. If you look at the P wave, it's kind of coming up, but it's not associated with QRS, right? Not talking. So that is what is happening here. So in this one, there is complete dissociation. There is no connection. It's complete dissociation. And nursing priority is to assess for possible causes. I mean, we don't know what is causing it. Maybe it is MI, maybe it is fibrosis, maybe it is medications. Everything we talked about as reasons for type 1 and type 2 can be a reason for type 3 or not, complete heart block, right? So everything there can be a problem for complete heart block, because things start as, type 1. Or things start as first degree, then they progress into complete heart block. So what was the cause which was causing first degree or second degree? That will progress into complete heart block. So the causes are almost the same, but here the problem is it is kind of out of hand. It is not anymore a counselor, or it is not anymore just seeing the lawyer just to fix things up. This is divorce we are talking about. Okay, so because of that, this is going to be a priority patient. Anytime you have a complete heart block patient, it's going to be your priority patient. Remember that, because they have issue, they need pacemaker. If you don't give a pacemaker, it's going to fail, because there is so much so that ventricles can beat without the help of SA node. Because normally it should come from the SA node, come to AV node, then go down. I mean, that's how things should be. Ventricles will try to just beat itself maybe for some time. Even if they do, it's not going to be effective. It's not going to be enough. So it will eventually give up, right? Which means when I say give up, that means they're going to die, right? I mean, it will stop beating. So asystole. So we don't want to go there. That's why we want to give the pacemaker, making sure that things are taken care. Because if you get the pacemaker, you know what happens. It will take the work of SA node. It will help conduct. It will have that wires and leads into the heart, into the ventricle. Also, we can give little leads and wires where the electrical impulse can reach. So it is as if the patient is having a normal sinus rhythm. It's as if the patient is having a normal SA node, right? So the pacemaker will really, really help. Now, this complete heart block is just a matter of time before it goes into like our legal or really bad arrhythmia, lethal arrhythmias. Like you can get VFib, you can get SVT, we can get so many VTs. I mean, it can go to asystole. Everything can happen. So this is a priority patient. All right, but type 1 or a first degree, not that much. If they are symptomatic, that's another story, right? Like I said. Okay, so let's do a couple of ECGs to see if we can identify them. So this is the first one I want you to look at. What do you think? Okay, these are the questions which you're going to ask yourself. Okay, whenever you get an ECG, the first thing you need to ask is there any dropped QRS? Now we are talking about heart block. There is a lot of things you need to ask when you interpret EKG. We are talking about the heart block interpretation. In that, the first thing you are going to ask is there any dropped QRS? Now, in this one, there is no dropped QRS. Like you can see, there is a QRS T, P, there is a QRS T, P, QRS T, P, QRS T, P. So which means for every P wave, there is a QRS. There is no dropping. If there is no dropping, what is it? It's going to be, can you type in? If you can type in first degree, very good, very good. If there is no dropping, then that means it's first degree. Most probably it's first degree. And it is first degree because if you look at that, you can look at that, the PR interval, look at the PR interval, it is longer, right? It is correct. It is like definitely the same PR interval, but it is longer. So this is going to be our first degree heart block. Okay. Now, whenever you see this, initially it might appear to be like a normal one, but don't be fooled. All right. Always look at the PR interval and see if it is longer. Then that is going to be your first degree. Next one. How about this one? Might look a little. Okay, all right. I see the guys answering already. Very good, very good. Jency, what do you think? All right. Okay. So in this one, if you look at it, I mean, there is a P, there is no QRS, there is a QRS, there is no P. Then there is a P, no QRS. Then there is a P, there is a QRS. Then there is a P, there is no QRS. So basically, they are not having any association. There is a QRS, there is no P. So these two people are having their own separate life. Okay, the P is not, looking at what QRS is doing. The QRS is not waiting for the P to come. They are having their own way of life. So this is going to be the third degree heart block. And most of the time, the third degree, I mean, almost all the time, the third degree heart block is going to show you really symptomatic bradycardia. I mean, you can look at that, that's like bradycardia, and they will have symptoms. Okay, symptomatic bradycardia. And that's kind of going to help you a lot to understand that. All right. Okay. So that's the third degree. Now let's do some more. How about this one? How about this one? Okay. Nimi, Danya, Shiji, Tracy. Okay. If you look at that, one thing we can, eliminate for sure, that is not first degree, because there is a dropped QRS. You see that, right? So it's not first degree. Second degree, sure, this is second degree. Which type? How do we know? We will look at the PR interval. Good job. So how does the PR interval looks like? Look at that, the second degree. It's true, it's second degree. I see some of the answers coming. Okay, second degree, type 1. Okay, very good, very good, very good. I think most of you guys are getting it. It's type 1 because look at the PR interval here. It's getting a little longer next time. Getting a little too long the next time. Okay, and then he doesn't come home. Dropped QRS, right? Then again back to the normal routine. Again going prolonged. So this is going to be the second degree type 1. Okay, type 1. If the PR interval was same, then it was going to be type 2. But here we are going to say it's Venki back. Okay, let me use that name also. Second degree type 1 is also known as Mobitz type 1 or Winky back, right? So this is a Winky back. In case, you know, if it doesn't say type 1, if it say Winky back, you know what you're looking at. Okay, this is the one. All right. Good, good. See, we're getting there. One more. That almost looks like an asystole to me. Almost, you know, almost going bad, really bad. Okay. So yeah, that is third degree. I mean, if we don't pace this patient, then we will be doing CPR or I don't know what all we have to do. This is third degree, right? There is P. This is P wave. This is P wave. There is P wave. There is P wave. There is P wave. None of them has QRS with it. But then there is a QRS, there is no P. Then there is a QRS, there is no P. So both of them living separate life, and that is the third degree. Okay, really bad thing. Okay, let's do one more question. Here. There we go. Let's try that. A patient admitted for dizziness and fainting. The nurse is observing following rhythm in the monitor. And they're not saying what are they saying. We have to figure it out. But the question is, the nurse should prepare for which of the following? Okay, what is something we should be preparing for? We should be getting ready for. Okay, and number one, possible cardiac catheterization and angiography. Number 2, permanent pacemaker placement. Number 3, administration of atropine as prescribed. Number 4, continue to monitor for the progression of heart block. Very good, very good. I see dropped Q. Okay, first we have to figure out what it is. Okay, which kind, right? Okay, I think Linu is saying, now we are saying. Okay, great. I'm seeing some of the. Okay, all right. You know what? I'm going to put the poll here. Let me launch the poll too, so you get to do that too. Let's see if we can identify. I mean, you can get the answer. Awesome, awesome. So you must have got a little pop-up thingy there. You can just click on it and it will send us the results. Don't worry, nobody can see. It will just, you know, show the thing. Okay. So let's look at the problem. Well, it seems like there's a P, there's a QRS. There is a P, there is a QRS. There is a P, there is a QRS. And then there is a drop. I mean, oops, sorry. See, in between here, there is a drop. Right? The QRS is not there. And this. All right, there is prolongation in the PR interval. So if you have both of that, there is no Q in between and the PR is getting prolonged, we know what is the problem, right? We know it's second degree type 1. So if it is second degree type 1 or Winky back or Mobitz 1, what are we going to do? We are going to go for counseling first. Right? And who is our counselor? And that's going to be our third one. Let me stop the poll and then let me share it with you. What you guys said. This is what you guys said. So 95% of the people got it correctly. I am very proud of that. I mean, that kind of shows how much it was helpful for you to understand. I'm very proud of you. And those of you who did number 2 or number 4, you know, who sort of said that, I understand you. I know what your thinking process probably was, because you were thinking, this is second degree type 1. And we said, if it is second degree type 1, sometimes there is no problem. We will just continue to monitor. But the problem here is the patient is already having symptom. See, if this was not there, okay, if this thing was not there, if that was not there in the question, I would have selected maybe number 4, continue to watch. Because that means, there is second degree type 1, but it doesn't say that the patient is having any problem. It's like asymptomatic, right? So I understand what you are thinking, but in this question, it clearly says that there is problem. The patient is experiencing issue. So when we get to the questions, don't get sidetracked by looking at the ECG. That's one thing which probably happens. We are so concentrating on the ECG itself, and we are so confident and we are happy that we know what ECG it is, we forget what the question was asking. So don't do that mistake, okay? So we have to look at the question and we have to make sure that we understand it correctly. In this one, it says there is fainting, there is dizziness. So because of that, we are taking it as a symptomatic problem. It's a thing which we have to do something about it. It's not something we can just continue to monitor. We need to do something. And if we have to do something, what is the best thing to do? Well, we don't have to go for the lawyer thing first, and it's type 1. If it was type 2, I would have gone for that. If it was type 2, I would have gone for the pacemaker stuff. But because it's type 1, we will try with the atropine. Well, if it fails, then the next step. Okay, so the answer here for us is number 3, which is going to be the atropine, the counseling, right? So is that helpful? Are you guys feeling better? I'm sorry about the beginning part where there was, I think it was too much people than we could afford in the Zoom thingy. So that was the issue. But I'm so glad it worked out after that. Let me just stop this one. And there is something more important I want to say before we go, because I know I took a little longer. I told you guys it will be up to 10:30, but I know it took a little longer. It's almost really late for you guys out there probably. But there is something I want to tell you, okay? And that's this, before you go, all right? This, I know you guys know what it is. This is the caterpillar, and this is the cocoon, the pupa, right? And then there is the butterfly. Now, see, butterfly has to come out of this. I mean, that's how it becomes a butterfly. But it's very, very, very hard for the butterfly to actually come out of this thing. It has a small opening, and the butterfly has to really struggle to come out of it. But that struggle is needed so its wings get, really, really healthy. The wings get very strong when it does that. And that's why it's very important for the butterfly to go through it. Now, that's one thing I want you to remember about butterflies. Struggle is required, all right? But transformation or the struggle is required for this butterfly to go from this little worm to this beautiful butterfly. If that has to happen, struggle is needed. Hard work is needed. Don't go for shortcuts. It's not going to work. Okay, so unless and until you put the commitment, you put the struggle, you put the hard work, it's not going to give you the results, right? It's very important to understand that hard work is hard work. There is nothing which can replace that. You can work smarter, you can go, collect the best things possible, but still it has to be working commitment. It has to be there. So that's one thing to remember from butterfly. The second thing I want you to remember is butterflies can transform only once in their lifetime, just once. The caterpillar will become the pupa, and then it will become the butterfly just once in their lifetime. That's it. The butterfly don't live for long days, 1 or 2 days, and it's gone, right? But for us, transformation is possible anytime we want. There is no stopping you if you want to transform. There is no stopping you from going from a bad situation to the good situation. Either vice versa too. Anybody can transform anytime, as many times you would like to in your lifetime. But for butterflies only once, is still doing it. So that's a very important thing to remember. Now, the third thing to remember from butterfly is get out of your comfort zone. You know, it's very, 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 very comfy in there. Inside the pupa, cocoon, I mean, it can just sit there. It doesn't have to worry about anything. It is warm. It is nice. It doesn't have to think about what to eat. Everything is so comfortable here. But that is not going to get you the butterfly, right? That is the cocoon. That's the pupa. I mean, you just sit there. I mean, that's not going to help. This thing cannot fly. This thing is not going to look like a beautiful thing. I mean, actually, maybe something is going to eat it probably, right? So it's very comfortable, but you are not going to get where you are. This is not what you are. You are this. You are the butterfly. You can fly. But if you sit here, this is not happening. This is comfortable, but this won't come. Right? So if you have to really become what you want to become, you have to get out of your comfort zone. If you have been studying for 2 hours a day, and if it didn't work, it's not going to work even if you go for 6 days, 7 days, 6 months. If you study the same thing, the same way, it may not work. You have to change something. Maybe you need to put more hours. Maybe you need to, do more revisions. Maybe there is a lot of discussions which has to happen. So there is always something more which we should be doing from our comfort zone to get there. Now, the last thing, faith, right? You have to have faith. Things may be really going in the sideways or wrong way or not the way we like it. I mean, I'm sure you guys, most of you guys were planning to probably write the exam, maybe in April or May or sometime. And then the COVID situation came and things changed. I understand that. Maybe you have to postpone your dates, or maybe you feel like it's like frustrating to wait for so long to get a date, to write the exam. And maybe you're feeling like and there were people who were supposed to come to help you out. Maybe your parents were supposed to come, or maybe you were supposed to go somewhere and study, and all those is not possible right now because of COVID situation. I mean, I understand that. Everybody are going through situations like that. You are never alone. Okay, everybody are going through things like that. Financial troubles and people trouble and psychological trouble and what else, everything. But have faith. Have faith that it's going to work out. All right, there is a reason. Now we don't know what it is, but there is a definite reason why things are happening like this. I mean, we may not be able to explain everything now, but we will be able to explain later in life. So please stay positive, stay focused, know your priorities, and we will get there. Bye-bye. Take care.